Welcome back, everybody, to another episode of the Best of the Best podcast presented by the Brinks Armored Account. I am your host, Maverick Levy. Today's episode is one that I am very, very excited about for many reasons. Number one, Chris, as leading up to this, I've been telling people, I think you should be going on Rogan. I think you should be going on these big podcasts because you are uncovering the truth of what people know in the healthcare system, but just aren't talking about. And it's something that impacts every single person in the United States when it relates to their health. I will say Chris and I met on the plane. We kind of hit it off. He sent me a documentary and said, hey, I produced this documentary. Take a look at it, watch it. So I told him, I was like, I put it on the back burner for 3 months. And then one day, it was the weekend. I was like, I'm going to watch this documentary. And I was hooked. I texted you. I was like, this is insane.
I'm glad you got to watch it too.
Yeah. And, I said, let's go out to lunch. I want to invite you on the podcast. And here we are. So Chris, before we dive into the depth of things, I always like to give the guests the opportunity, give their background, talk about who they are, how they got here, and now what you do for a living. So the floor is yours.
I appreciate that. Thanks for having me back. Really appreciate this environment to tell the story because it's such an important story, one that people don't really see or understand, and it has a lot of misconceptions, misnomers in it. Mm-hmm. But by trade, graduated here in Florida out of a major university, went into law school for a little while. Did not like that, but I got fundamentally a great education from it. Ended up leaving. Found myself
Did you know I left law school too?
No, I didn't know that.
13 days.
Really? I made it the entire first semester and 3 weeks into the second semester.
Okay, so you beat me. Yeah.
And I think I walked out in the Federal Rules of Civil Procedure class. He came. I had a former Harvard University teacher. I forget his name, professor, and he came in, and I just remember that book where you go through. You got to go from here to here to here, and we had to read 300 pages that night and come back, and I was just like, this is just not for me. But I love the education. It made me smarter as a business person moving forward to understand contracts and really how a lot of things can function.
Yeah. Sorry to interrupt you. I just didn't know.
I think that education maybe helped me see some of the things that you'll see here today, to identify things that maybe I probably wouldn't identify today had I not had that base education. So that's interesting. Right. So ended up struggling after that, trying to find my way. And I eventually always liked healthcare. I knew it was an industry not going away. And a friend of mine was working at a large insurance carrier. It was actually United Healthcare at the time. And I went in for a sales position, and I ended up getting hired. And I worked there for, I believe, almost 8 or 9 years under a great CEO, learned the whole business, how it's built, and eventually left there to Cigna Healthcare, where I followed my CEO. He kind of recruited his team.
Yeah.
And that's really where I got the education to do the documentary, a lot of it. I think some law changes that opened up my eyes, and some transparency that was this hidden secret, if you will, of insurance companies. Wasn't even a lot of it privy to us as we worked there. I realize that now years later.
Yeah.
But I would say that background education helped me do what I do today, which is as a private consultant, going out and managing healthcare plans for large and small, mid-sized cap corporations, trying to teach them the in and outs. I would say, it's funny. So a lot of lawyers go to work for the state prosecutor before they become defense attorneys. Right. You've heard of that. Right, and so a lot of the good defense attorneys used to be state prosecutors. So they know what the state prosecutor is going to do before, day one of trial.
Yeah.
Right.
Yeah.
So I know what the insurance carriers are going to do, and I'm there now on this side of the fence to represent my clients to really navigate them through that process, which the majority of them have no idea how displaced it is against them. And I say just the misalignment of incentives, right, within the entire vertical of the system.
Yeah, and I was definitely one of those people that had no clue. I always knew that costs continued to rise, but you really didn't know where the money was going and how crazy the pricing is. So it's truly fascinating. I mean, what made you want to create the documentary? Why did you want to do that? What was the inspiration behind it? Because at the end of the day, it was you going out and doing something that you didn't have to do. So that's part of why I loved you and I was impressed by you, because we had this conversation at lunch. I view myself as focusing on industry disruptors, right? Anything that's disrupting an industry, I'm fascinated by. And I have not been as fascinated as I was by your documentary in a very long time. And I think the reason for that is, honestly, people are scared. They're scared to show the truth. They're scared of the potential consequences. So all of that being said, why did you choose to produce the documentary?
So it's a great way to tell your story. And not everybody has time to sit, or CFO or president of a corporation or CEO has time to, and I can't reach every CEO or CFO in a day, but if they watch my documentary and they watch, or they take it that time on their own time, like you did, eventually I get a call. Hey, can you help me with this? I see this problem in my business. I have the same profit leak in my business.
Yeah.
I have the misalignment of incentives. I haven't been asking the right questions of my advisors, which I really need to. So it was a great way to meet a vast audience very quickly to tell the story. And hopefully more people watch it, especially executives of companies, because it can really change the way the business works. It can improve the bottom line and EBITDA to the business. So CEOs and CFOs can go back and tell the board that they made a real impact, and a real impact that improves the value of the healthcare dollar to the end user and the employee. I didn't want to see, and we'll talk a little bit about it, but we started a healthcare navigation company because we saw these types of things happening. And I say these types of things, I think I've told you the story before of a sleep study, $3,000 deductible. Primary care doctor recommended this young woman to have a sleep study. We monitor, one of the things we do is monitor pre-certifications in a company, so we can see what I will refer to as the healthcare supply chain management, right? And so one of the things we'll do, especially with an employer that's self-funded with the TPA, the third-party administrator, is we'll request that any pre-certification, and pre-certifications are going to be major, more major healthcare services, right? They're not your doctor office visits. Sometimes they can be prescription drugs, but again, no doctor office visits. You typically will see it for the more costly stuff. So MRIs, CAT scans, PET scans, a surgery, in or outpatient surgery. So what happens is we'll monitor that, and we'll see where a patient was referred to, where they're going, and we'll actually go in and measure the cost and quality of the physician they were referred to. And why is that important? Because every time you have bad health care, it can be costly, right? Recidivism rates, having to go back to have another surgery, or, this facility has a high ranking for infections, sepsis, right? With it just not a clean facility. Those types of things cause healthcare costs to skyrocket, of course. And then there's huge variances in cost between providers. Literally, one provider just down the street could be tens of thousands of dollars different, and it's just the facility fee. And the surgeon does surgery at both of those facilities, but by going to one, you're really driving the cost of care up for the entire organization and your entire company.
Right. The question I was going to ask is, what was your initial reaction, right? You've been in this space for 20 plus years. What was your initial reaction when you realized what was happening to the consumer with price gouging, with the difference between pricings in one medical facility and the other? What was as Chris, the industry expert, what was your initial reaction to this?
I was shocked. I couldn't believe it. Looking back on it, to think 3 decades of this have been launched on American companies and those employees that work for those companies. Not having transparency. And what really changed it is and I think we've talked about this before, is TICRA, the Transparency and Coverage Act.
Let's dive into that. Explain that for everyone.
So This law was passed that basically said that providers are included in it, but every insurance company had to disclose their what we call machine readable files, which are the files that show the pricing of all the CPT codes, how much a facility charges for a particular price. Prior to TICRA, you couldn't find that. You couldn't get that data. You had no idea how much a large insurance company was paying a provider for that service. You went in blindly to it, right? Maybe you had a $250 copay for an outpatient surgery, right? And so you as the consumer would go down, look through a book, huge book, or go on the internet, and you would search for a physician. By the way, about 66%, based upon data I see and we use at NavSys and Navigation, about 66% of the doctors out there or providers are high cost, low quality. That means you have about a 33% rate that the doctor you're going to pick is of high quality and charges what we call a fair price, some sort of median fair price.
And
right?
How is that fair price produced? Is that where it goes back to the cost of the Medicare cost and being reasonable to the Medicare cost?
Reasonable to that region's average cost or median cost, right?
Okay.
And I could show you a slide, and I'll go to it. So here, this would be a great example. Sorry for the misspellings there on the left side. But you'll see here on a CT scan, in Miami-Dade County, it has a 1,600% variance in cost. You could pay $178 at one location and walk into another facility and pay upwards of $2,857. Well, how does that impact the company? And how does that impact its employees? That's huge. Because without TICRA, the ability to see this and this be transparent, again, an employee could have two things for this, two ways of paying for this. Either their employer on their benefit plan has it as a deductible and co-insurance.
Yeah.
Right? At which point, that's really important because if this is subject to your deductible, right? And let's just say you have the average deductible in America, according to Kaiser's, I think $4,300. But let's just say you have a $4,000 deductible, right? So you're going to be responsible for the full contracted rate at that provider of the cost.
Yeah.
And without seeing this, you could end up at the provider that's $2,857.
But as the average consumer is looking at and using the chest CT scan as the example, I'm just listening to my doctor, right? My doctor saying, hey, go and get a chest CT, and you don't even think to ask pricing versus here versus there. Why is this not more so rooted in the doctor saying, hey, go to this place, or hey, go to that place? Because now it becomes on the consumer. So now they have to worry about going to get a chest CT scan. So they're already worried and nervous. Is something wrong? And are they going to find something? Sure. But now they have to worry about the pricing and making sure they're going to a place that's reasonably priced. My question is, why are the doctors not more focused on ensuring they're sending the patient to a place that's cost effective?
I think they're starting to become more conscious of it. When my medical director engages some of these physicians, they understand that conversation. But remember something too, we live in a system in America that's a for-profit healthcare system, okay? And so if you're a physician associated with a particular hospital, right, and you work out of that hospital, you're typically going to refer your patients back into your hospital setting, into that business setting, into that environment. And it may not even be, maybe you're trying to drive business there, maybe you're a good steward of the corporate culture, right, and trying to keep everything in-house. Maybe you just have a great relationship with the physician upstairs and you think that physician's the best, right? And so you get in your healthcare system because you interact all the time. But it doesn't mean they're the best. Like I tell people that, a good hospital name doesn't mean you always get a great doctor.
Right.
Right?
Yeah.
And not all hospitals are good at everything. So you can look at rankings of hospitals, and the hospital could be the best in top 10% of all hospitals that do cardiac surgery.
Do you think the the doctors are aware of the difference in pricing between their hospital and another hospital or another surgery center or facility?
They're starting to, yes. And they certainly know.
Why do you think now is the time that they're starting to? Because prices have gotten so
Because
outrageous?
it's transparent, and TICRA has pushed that. So as of 2024, every insurance company must show their pricing in machine-readable files, actually on their website, and every provider must. But if you go on some of the websites of hospitals, go try to find that pricing.
Yeah.
Luckily, there's been aggregators of this data that have gone in, pulled it out, and put it together in a shopping tool for it to make sense for employees when they shop for healthcare. So they can recognize, hey, I'm going to a facility and the CT scan is going to be $2,800. In some cases, people avoid care for that. They leave. $2,800. I don't have that to spend today.
Right.
I'm not going to get the chest CT scan.
Right.
By the way, a chest CT scan picks up plaque in your major arteries in your chest, in your heart, in the artery, to see how much blockage is there.
Yeah.
It's huge. I get them. Actually, I go to a local hospital here that offers it during Heart Month for $99. You can purchase that for.
And is that out-of-pocket cost of $99?
Out-of-pocket cost. I pay cash for that. And I do it preventative for myself. It wasn't ordered by my doctor, right? But I grew up in a family that has hypertension. My dad had a triple bypass when he was, I believe, 65 years old. So that type of predisposition towards plaque building up is there in my genetics. So my doctor didn't, or actually, I had a doctor recently ordered, a cardiologist, but I'd been getting that test for years before that. As a matter of fact, when my cardiologist ordered it, I said, I already got like 2 or 3 of those. Do you want the data? And it was great. So because now I'm aging, getting a little older, and when he asked me, hey, I was suffering from high blood pressure at the time, you should go get the chest CT scan. We looked at it, my blockage was 6%. What was great, though, is that I had the legacy data. We could look back on it and see that I had 0 in this year, 0 in this year, 0 in this year, and just about this year, you're starting to build plaque. So we know that my body's changing, right? And it's starting to hold that in, and I'm not able to, obviously, break that down as much as I used to when I was younger. So that means what? Diet change, exercise. Those are things I need to be conscious of.
But
right?
You being Chris, you know to go and do that. You understand the value in that. How do we educate the consumers on the value of this? And in addition to that, going to this place where, hey, during Heart Month, it's $99. I just feel like the message is not getting delivered across to the consumer correctly, and the knowledge isn't there for them to make that decision by themselves.
That comes with personal responsibility, right? And I could tell you, I've been shocked. We've had care guides call people. I've seen people diagnosed with cancer not do anything about it, not follow up with their doctor, not want to follow up with their doctor. We've called, hey, you were diagnosed. We're looking at the records. What are your follow-ups? And sometimes they just ghost us. And we know they're not getting care because we don't see the claims coming in for the treatment of it.
Yeah.
And so what did some people, look, you heard of white coat syndrome? Some people are terrified of going to the doctor and getting over that.
Yeah.
I mean, I was as a kid, right? You got to get past that and understand that 90%, like 90% of cancer is treatable if you catch it early, right? But you got to be not scared to catch it early.
Yeah.
Right? You have to go down and see or
let's use that
surgery.
scenario for a second. And obviously, I'm giving you a tremendous amount of pushback on some of these things because that's the goal of this conversation for me is I want the consumer, I want the audience to walk away having learned I can go and get these things done for a reasonable price, but more so how important it is to go and get these things done. Because yes, people talk about it, you hear it, but it's usually coming from someone that is a doctor, right? And when you talk about white coat syndrome, it turns them off a little bit. But when Chris and Maverick, someone that's selling you health insurance and someone that's here to ask the questions are talking about it, maybe it perks their curiosity a little bit. But in that example you use, okay, I went to my doctor, he ordered a CT scan. Again, now we're flipping it back onto the consumer. Once it's ordered, now figuring out where is the cheapest place to do it because they listen to the advice of the professional. And I think that is, to me, one of the biggest takeaways after watching the documentary, talking to you, going out to lunch with you is the consumer is listening to the doctor, right? They're listening to them, they're trusting them. everyone's looking for the best doctor. Okay, I go to this doctor because my cousin Nancy and my uncle all went to him. This is a great doctor. But what have you done besides that to validify that that is a great doctor and validify what he's telling you in a place to go is a great place to go, right? Then that flips back onto you. And that's where I think we need more help. We need more assistance as consumers. How can we get to that point?
So that's the whole point of the education. Certainly when you roll out corporate insurance to a group of employees, you have that opportunity at that point to educate them. A small window, but maybe it's a half an hour in an open enrollment meeting. Maybe they sit with their benefit counselor. So you got to set the narrative at the beginning and provide the resources, right? But the reality is most of us walk out of that room and forget about that. And we forget about it until we get sick.
Yeah.
And then now is when you need the resources. And a lot of times it may be 6 months, 8 months later, and you don't remember what I said or what that consultant said in that meeting.
Right.
And that really is the point of our navigation company.
Right.
Hey, we just saw the pre-cert come through. We know this person's entering a stage where they're going to need consistent health care or cancer treatment, or they've been diagnosed with a chronic or acute illness, so they're going to need support. So that's our proactive approach. We reach out at that point and start to re-educate at the point that they need it most. It's meeting them at the time that they need it the most, because the odds are that they forgot about everything that we told them 6 months. And so we'll make that outreach and say, hey, here are resources, right? Don't avoid a chest CT scan because it's $2,000 and miss care and then cause further issues for yourself in healthcare because you didn't address it with a blood pressure medication or a cholesterol medication, right? We want to engage you and say, hey, and we've done it before where we've called, hey, I didn't get that test done. Why? Well, they tried to charge me my full deductible, $3,000. So what'd you do? I left.
Yeah.
Oh my gosh.
Yeah.
How can we help you with that? Did you know that you could buy that same sleep study test for instead of $3,000, $280, and they ship it to your house through FedEx? You plug it in, you sleep with it, and ship it back. Now the care is affordable, right? If you avoid care because it's unaffordable,
But without
have
you, they don't know that.
They don't, and that's a big gap, I feel, and that's part of why we try to push the narrative, why navigation is so important when you have a corporate healthcare policy.
Yeah, and something I took away from the documentary, and I forget, she's a former nurse, and basically she helps patients talk to, what's her business? That nurse?
Deb Alt.
Yes.
Nurse Deb, yes.
Okay, so, one of the biggest takeaways I have is that phone call between I don't know what it was, a pharmaceutical.
I believe it was a hospital provider.
Okay,
and it was for a medication. For Keytruda,
and
for treating cancer. Yeah.
And the cost of that was $70,000. That's what they were telling them.
Yep.
And really, that same medication costs $6,000.
Yep.
So the profit margins are outrageous. Outrageous.
And the response is, well, if the patient doesn't get it, they'll die.
Exactly.
So what's the upper level ceiling in cost in healthcare?
Exactly. And that's my point, is saying, if that's the attitude, how do we change that? Do we change that through regulators? Do we change that through legislators? Does that even change? Do you see a foreseeable future? I mean, you're talking the healthcare industry, which makes up 20% of the overall GDP in America. And these people can't even afford a medicine to treat their cancer because the cost of it's $70,000 when the true cost for the company is $6,000. So how do we get to a point where it becomes more affordable?
So keep in mind that the actual person getting that script, right, probably met their out-of-pocket costs already on their health plan. Okay? So who's really paying for it? The employer.
Yeah.
Right? At the end of the day, in that situation, because the employee's maxed out on what they've had to pay. Now the insurance company, if you're fully insured, they're on the hook. Okay? And by the way, we know they're not trying to drive some of those costs down. Right? So $70,000 bill, it could be a loss. It could not be a loss to them in some capacity, depending on where they are with that business in terms of the loss ratio at that point. But essentially, the end pair of that being the employer has to set some sort of controls in place to make sure that those things, at least you can regulate some of them. You're never going to be able to regulate all of them, like emergency care.
Yeah.
How can you step in emergency care? And I'll show you same chest CT scan at $9,000 in an emergency room. I pulled the machine readable file for the insurance company and it was contracted for $5,300. I says, well, how did the provider get away with charging $9,000 and let the carrier pay for it through the TPA?
Right.
Oh, they use some sort of special coding now to upcode it. And I recently found that a lot of providers, large hospital chains, bring people in to teach
What does that exactly mean?
upcoding on CPT codes to bill as much as possible. Right?
I want to walk
like a
that
Tylenol.
through. Yep.
That's $1,600 and it's written down as pain management. But then when you really get down to it and you audit the claim, you find out they just paid $1,600 for Tylenol.
And what happens after that? What is the consequence of that?
You fight the provider on it. Hey, this is miscoded. It was Tylenol. You coded it as, pain management. Well, it's Tylenol pain management? Yeah, it is. We take it when we have a headache or an armache, right?
Yeah. So
it could be classified as pain management.
So going through the process, right? Someone goes into the hospital. They are in the emergency room. It gets ordered. They need to go to CT. They get a CT. Whatever paperwork happens, then let's say goes upstairs to the administrators. Is that when they're upcoding it during that process?
A CT scan is one code.
Okay.
So it's difficult to upcode it. Where this will typically happen is when there's multiple procedures or medications being administered. So a complex hospitalization for sepsis, where doctors are coming in and out of the room constantly, nurses are coming in and out of the room, they're constantly administering different medications, constantly doing blood tests and blood work to see how those medications are reacting on the patient. They're working, they're not working, and there's just tons of billing going on, right? And you'll see if you've ever been hospitalized and you have one of those bands on your wrist, right, it's got a barcode. And every time that nurse comes in, it's tick, 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 just like you're checking out at a grocery store, right? And every single one of those codes is going in as something administered to the patient. Well, most people that audit claims find that 99% of those, there's a mistake in 99% of every hospital bill. Most people will tell you. And it's that type of charging. So a lot of times on those big hospitalizations, you want to go in and audit that. Okay, what are we paying for, and how much are we paying for it? Are we overpaying for it? Did they miscode something in that case?
Yeah.
And so it just builds up, and you get this long hospital bill with all these codes and all of these charges, like you just pigged out at a huge buffet.
Yeah.
Right? Or a restaurant, and they were line iteming you at every charge, and the bill comes and you look at it. I mean, listen, you go out to dinner for Thanksgiving dinner and you have 20 people and you go to a restaurant, there's going to be a mistake on that bill.
Yeah.
I guarantee it with your own family.
Yeah.
Right. And so there's a lot of that charging, and then you could two procedures are so similar, and you can upcode it by using one that charges more. You essentially upcode it to that one, round it off to that code. Or could it be, so a lot of that's going on in there, and a lot of that trickery, and hospitals are bringing professionals in to learn how to bill insurance companies, professionally billers. And so, that's one of the things that helps drive healthcare costs.
And the insurance company, how often are they fighting the hospital administration on the billing aspect of things? Not very often, I'd assume.
So they do fight it. And keep in mind, there's different business segments. And clearly, if you're in a fully insured business segment, where the carrier is going to keep any of that cost as profit, possibly on that, you'll see auditing in there by an insurance company, because whatever they're able to not pay the provider, right, they get to keep his profits.
Wow.
Right? Think about that. And then they don't give it back to the customer and say, hey, you're on our fully insured product. We found out that this claim was overbilled. Here's your money back. That happens if you're self-insured, right? And you find a coding error. But in that environment, the insurance company keeps the money.
What's the craziest coding error that you've found thus far in your career?
I wouldn't say it was an error. It was done on purpose, and it was and I'll actually show it to you here.
Yeah, please. So this
was one that I caught and my team. So this individual was hospitalized in an ER, and you'll see up to the right side that the pair or the hospital, which over here is HCA Florida, North Florida Hospital, builds the insurance company through the provider, and this is a self-funded plan TPA, $17,749.49 for a chest CT scan right there.
$17,000.
$17,000 was billed for that. And the claim settled out because, again, what they do is the smoke and mirrors. Like, here's the full cost, and the value of us is that you get to buy this at a discount, right? The fallacy of it, right? So there's the discounted price off to the right, $9,027.56. And as soon as I saw that, I'm like, well, $9,000. This is a test. I can relate to this test because I get them.
Yeah.
In a non-emergency situation.
Yeah.
And I pay $99 for it. Now that's gouging. That should never happen in the planet. So what I did is I went in and I said, okay, well, let me go look at this insurance company, and I'm not going to name the insurance company, but let me go look at this insurance company's cost for this CPT code at this provider. And so when I did that and I caught it and I got the machine readable file, it's $5,948.
Oh my God.
So that's what we expected to pay. And when we dug further into the claim, I found this new process, and I think it's maybe these billing experts that are teaching providers and hospitals how to do this, but it was something called custom coding. I says, well, wait a minute. What's the whole point of the TICRA law if I can see the transparency of how much it should cost under the CPT code? But then I actually go to get it, and it's nearly twice the cost.
I just don't understand.
And it gets billed, and we try to fight it, and we can't. The insurance company allowed it to happen.
So there's no fight there.
There was no fight there. They allowed it to happen. Maybe there is still. I still think there's some hope for a fight. I want to go challenge it.
Yeah. And what does that look like when you challenge something like that? Or can you give an example of something that you have challenged in the past and what the result was?
Yeah, you go back and say that's unreasonable. So I think I had told you before that the Affordable Care Act said that a provider must charge a reasonable amount for a service.
Yes.
Well, we could go back on that and say, hey, this is egregious. You should not have been allowed to do this or overcharge us for this. But something in the insurance company's contract says otherwise, according to this, right? That, hey, this is something in the contract is allowing the provider to go from the $5,948 up to the $9,000, and the insurance company to say, you're right, we're allowing that. Now, can I go in there and challenge that? Yes. I don't know where. I'm not privy to those contracts. I can't see them. I don't know how they're doing that. I know that the machine readable file tells me it's $5,948, but for some reason we're getting charged $9,000, and the insurance company let it happen, and it got paid. Now, how could you fight that today? Look, it's unreasonable charge, even if it's contracted. The contract's unreasonable.
I just can't wrap my head around how this is even allowed. I really, seriously, I can't wrap my head around. Is it corruption? It's a
for-profit system. It's a misalignment of incentives. And really what happened is, again, it goes back to it's the ACA rule on minimum loss ratio that said that the minimum loss ratio for every dollar paid out, 85 cents had to go towards paying claims. So how can I push, if I'm the insurance company, right?
Yeah.
How can I push my profits higher? Well, by everybody paying more for healthcare. And so now that makes you as a business owner and me as a major health insurance company, our incentives aren't aligned,
Yeah.
right? And it would go against all my business senses not to create profits. And if the Affordable Care Act says that I can only take 15% because of the minimum loss ratios, right? 15% of 200 is $30. 15% of 100 is $15. So how do you push up your top and bottom line with Wall Street and become profitable? And this is how it's happening, right? And if I'll show you some other slides on inflation since 1999, it's nearly 300% in healthcare comparatively to about 89% from 1999 till I think it's 2023. All other inflation was about 83%. Healthcare, it's nearly 300%. And this is how it excels. Who pays $9,000 for a chest CT scan? Even $5,000 is egregious.
So to make sure I understand correctly, because of the Affordable Care Act known as Obamacare, the carriers themselves have to, it's the 85-cent rule on the dollar.
It's called the ACA rules on minimum loss ratios.
Okay, got it.
It's embedded in there.
So they are just said, okay, well, if you're going to put that on us, then here's what we're going to do and continue to raise prices.
But think about what a deception.
It's insane.
Because let me explain the deception to you. So here you are, right? And your message to the American people is, hey, the Affordable Care Cost is going to control costs. Why? We've limited how much money the insurance company can make. We told them that every dollar they collect, they can't just be egregious with their profits. 85 cents of that has to go to pay claims. Sounds good.
Yeah.
Doesn't it? It sounds like a great narrative to go tell the American public. We're going to save you money. This is how we're going to do it. We're going to limit their profits to 15%. Okay. Well, when you're charging $9,000 for a chest CT scan,
Yeah.
right? And I get 15% of that, right, as profit. Well, charge $17,000.
Yeah. Why aren't other brokers like yourself talking about this? Is it because greed and money?
So I don't refer to myself as a broker anymore.
Okay.
And it happened after doing and producing this film and learning all that I've done. Because I want to get myself out of that name.
Yeah.
To me, it's a
That's
bad
fair.
name. It's the person who shows up in the executive office or in HR and has 5 carriers and spreadsheets and says, this one's the cheapest. This one's giving you a 10% increase. This one's only giving you 5. Go with them.
Mm-hmm.
Okay, that's not consulting. That's not controlling the supply chain, the healthcare supply chain of how your employees are consuming it. And that's the game of whack-a-mole. That's a broker.
Yeah.
Okay, a consultant is somebody that comes in, looks at this, looks at the claims, looks at the possibility of saving. So I'll tell you, one of the things I can do today is I can go into a large corporation as if they're self-funded. Again, when I use self-funded or fully insured.
Can you go through what that means just in case people don't understand?
So fully insured is where I've employed the insurance company, major insurance company, to handle all the administration 100% of my healthcare for a monthly flat fee called your premium. Okay? You have 1,000 employees, it's $100,000 a month. You pay the insurance company $100,000 a month. They fully insure all of your employees under the benefit plan guided, and that's what you pay them, regardless if they pay out 85 cents in losses for the utilization of your employees' medical, or whether you had 150% loss ratio. Now the insurance company took it on their back, right? Because they undercharged you for your risk.
Yeah.
Right. So that's fully insured. And in that environment, the claims data you get, it's very muddy. It's not clear. You don't get data like I get here with CPT codes and tell me where every dollar's going. They're going to give you averages. You paid us $100,000 this month. We paid out $65,000. You gave next month, January, right? February, you gave us $100,000. We paid out $150,000. Okay, they were upside down that month.
Yeah.
Next month, you gave us $100,000. We paid out $40,000. If you have a lot of the months where you're giving them 100,000 and they're paying out 40 or 50,000, you've left a lot of money on the table,
100%.
right? And that's why you would want to look at claims data and say, hey, wait a minute, what environment am I best in? Do I have high risk? Do I stay fully insured? Even if I have, and the misconception is high risk, stay fully insured. No, you're going to get killed in that environment because you're going to have no cost controls.
Right.
That's the exact opposite thinking you need to have. You need to get out of that and say, wait a minute, our claims are skyrocketing. Why? Understand the fundamental problem. Are we overpaying for services when we purchase them? Like this.
It just seems so crazy to me that this is allowed to happen.
It is.
And I think it's because there's not enough people that know that this is even happening. It goes back to the trust in the doctor, the trust in the healthcare system. You think, like, I'm from Michigan, and there is a healthcare system that people say is superior to the others. And so they choose to go there.
Superior how? What does that mean? Right? If I walk into a room of employees and I say, what do you think good healthcare is? You know what their answer is going to be? That I could go see any doctor I want to. Whoa!
Right.
That is the worst. Because I know that 66% of the doctors out there are low quality, high cost.
Yeah.
I want to create what I call super high efficiency networks.
Yeah.
The best doctors at the best contracted rates.
Yeah.
Right? I can do that in self-insured. Right? If you walk up to a major carrier, here's the whole book, go wherever you want. So your exact or the average person's thought process on what's good healthcare, that I can go to any doctor I want, is completely the opposite of me sitting on this side of the table. I don't want you going to any doctor you want. I want you going to the best doctors that aren't going to have a high recidivism rate in clean facilities that don't give you infections.
Yeah.
Right? And where are you getting that data from when you make that decision? Right? Who are you talking to when you make that decision? Listen, your doctor, your primary care doctor, your musculoskeletal orthopedic specialist that you went to for your knee is not going to tell you when he refers you into the same hospital system that they got a terrible infection rate. It doesn't even become the subject of what you're talking about.
But that's what I'm saying. Shouldn't this be something that's obligatory?
It's not. The patient has to be educated. And if I brought my medical director in and maybe one day you'll speak to him, he'll tell you, you have to be prepared as a patient to ask the right questions, right? And he'll tell you, because you have a sales meeting, right? Mm-hmm. You'll sit and prepare for that sales meeting, understand what you're going to do, run the numbers, have everything down before you walk in that room day one to pitch that sale, right? To understand everything. You're diagnosed with cancer, you're going down to see your oncologist, your doctor. Have you sat down and prepared for that meeting? The most important meeting of your life, probably.
Right.
You've done no preparation.
But that's because you're instilling the trust in the healthcare system. And basically what you're saying is you can't trust it.
You can't trust it. Look, was everybody in your law school class top of their class?
No.
Or there's some really bad lawyers, right? Or it's just scraped through with C's and D's, right? Not everybody's top of their class. And I'd rather get you to the top of the class.
Yeah.
Know that you're going to get the best outcome in surgery the first time, right? And do it at a fair price, not gouge me. And so that's the job of us as the navigator, to find you a fair price and the top doctor to do the surgery at the top facility. And guess what? You may be shocked when we tell you that, Cleveland Clinic isn't the best at this surgery, but the hospital down the street, which is a lot smaller, is the best at gastrosurgery. Yeah, Cleveland Clinic's great at cardiovascular surgery. They're ranked in the top, but not for bariatric surgery. They could rank at the bottom. I'm not saying they do, but
you're giving an example.
These are the things that the misconception is a big hospital name, I always get a great doctor. No, and they're not great at everything. You have to do the research, just like that sales meeting. Is this the right doctor for me? Is this procedure the right procedure? And remember, sometimes that is outside of your regular treatments, meaning what the American Medical Association says is a standard treatment protocol. There's a lot of physicians that don't accept insurance, or facilities that treat cancer. Some of them are amazing out in Scottsdale, Arizona. One of them is called Invita Medical Centers, Dr. Dino Parado. I saw some amazing things done there for cancer that had people survive. He doesn't accept insurance, it's cash. But things that are non-invasive. where that same treatment at a major cancer center out there would have been $180,000, and he's charging $25,000 and is less invasive, and the patient's walking out 45 minutes later cancer free.
And is that
but
just
the American Medical Association doesn't allow it.
Is that just because he's a good person then? What is his incentive to operate that way when he could be operating and make $150,000 on the same thing?
There's a lot of people that don't do it for money.
Well,
and he's one of them.
That's what I'm saying.
When I saw his facility, I said, this is the most amazing facility I've ever seen to treat cancer, and some of the things you do here are so advanced, and they're so advanced that the American Medical Association's behind, right? There's a whole new subject matter on integrative medicine that's just for you. But health insurance companies aren't paying for it today, and they keep people healthy. I pay for it out of my pocket. I actually went and purchased an HSA this year, a health savings account, because I use alternative medicine. I do genetic testing, and I take supplements based upon my blood work and my genetics specific to me, that my blood work was out of whack before I started doing it. By the way, none of these are pharmaceutical drugs. They're supplements. Mm-hmm. Like, for example, one methylfolates to break down folic acids in my body. I was having terrible digestive issues. It was, and the source of your stomach feeds all your other organs.
Right.
Like how aware you are of this. And so this new integrative medicine is really changing lives. It's keeping people healthy. It's making them feel better because they're doing what they need specific to their genetics and their blood work, and not just, American Medical Association says for this type of diagnosis, these are the 3 treatments and that's it.
Yeah.
Well, what if your genetics didn't respond to those 3 treatments? And I'll give you one thing that I learned out there. I learned that cancer cells aren't always awake at the same time. They don't eat all at the same time. Like of that cell, of that tumor, 30% of it could be awake. 40% of it could be awake. Okay, so what happens when you give it chemo? 30% of the chemo is absorbed, maybe 40%, because the rest of the cells are sleeping, which is why you have to do the chemo over and over and over again. And Dr. Prado showed me, he's like, we actually take a biopsy of the tumor. We understand what it eats. We then feed it, so it's 100% up and eating, and then we hit it with the chemo.
Wow.
So it's all eating at the same time to reduce how many times we have to give that patient chemo.
Wow.
That was the basic understanding of it at a non-advanced level. I'm sure it gets much more technical than that when you get into it. But these are some things I was just like, wow, that's incredible. I had no idea that could even be done in medicine. Taking the genetics and the blood work and looking at that individual different on how you're going to attack that cancer versus saying, you know what, this diagnosis, these are the 3 treatments by the American Medical Association. Pick one of the 3. Let's see if it works.
Your data and your evidence supports that that high cost does not equate to good quality in healthcare, right?
Yep.
Was that always the case?
I mean, I had the same perception everybody else did until I started to see data like this, that cost and quality, like everything else we consume in life, right, is correlated. Yeah. And when I got into this data, it was just shocking to see there was no correlation to it.
But let's say like 1980, 1970, and maybe you don't have the data to show that because there was no Transparency Act. Sure. But does your gut tell you that it was the same back then, that high cost did not equate to good healthcare?
Remember, the system was different before HMOs back then, right? 70s, I think what HMOs came around early 80s. I can't tell you. I think it was, but I remember as a kid going to my doctor, and we had a Blue Cross Blue Shield PPO. It was like an indemnity plan. You would go to the doctor would charge you. You'd actually pay, and then you would submit it to the insurance company. Yeah. By the way, that was transparent. Yeah. That was probably the best system we had at the point. But then what did we do? Well, the HMO. All the contracted rates, you have a copay. Consumer sees no transparency. Right. That was the end at that point. That's what, and we got into that 3 decades now of this and haven't saw or even understood what a hospital bill looked like.
So do you think the system was set up to be this way, or is this just what happened over time with greed and corruption, or was someone sitting there saying, when we set these codes up and when we do these pricing models, this is going to be the way it's going to be? Do you think that dark of a conversation had happened?
I would tell you that there were some really smart people who did this. Extremely brilliant. So brilliant that it took 3 decades to even start to unwind it, right? In a consumer environment. And it certainly wasn't done by accident.
Yeah.
When you look at the detail of it, when you look at, I mean, where else can you charge somebody $9,000 for a procedure that should cost $200? I mean,
it makes it. That's again.
I get away with it.
I just can't fathom it. Like I said, I've watched a documentary you've produced now almost 3 times, 2.5. I just can't fathom that this is happening, that this is allowed, that this is our healthcare system, but no one's talking about it. No one's talking about it at all. People are talking about we don't have enough doctors, which, again, another important topic. Sure. People are talking about rising cost of the food at the grocery store. Okay, great. We need to keep an eye on that too. But what's more important is, why is someone getting charged $17,000 for a scan that should be a couple $100?
Well, I mean, look at it. According to what I was just quoting, inflation from 1999 to 2023 was 83% on all other consumer products and just under 300% in healthcare. Mm-hmm. How did that happen?
Do you think the pendulum is shifting? Like I've been asking you, doctors are starting to think about this more thoroughly, communicate it more.
The TICRA laws helped, and believe it or not,
what was the root of the TICRA laws, by the way? Do you happen to know
that? To
make
this transparent.
But who lobbied for that? Do you have any idea?
And don't quote me. I believe it was under the first Trump administration.
Okay.
And I believe, that's why a lot of major corporations don't like him.
Yeah.
Especially drug companies, and insurance companies in some respect. A lot of these huge corporations aren't fans of that. He let the secret sauce out. TICRA let the American public really see what was being charged for healthcare services. And, when you start to see that and you look at that, you just become shocked.
Yeah.
Just the CT scan alone. So it was the implementation of it, by the way, was over a series of years. So like in 2022, you had to meet a certain threshold, 2023, and now in 2024, the threshold is that all the providers must have it too. So technically, I believe in 2024 today, you are supposed to be able to walk into your doctor's office, hand them your insurance card, and they should have the ability to tell you exactly how much it's going to cost. Or what they give you, what's called now is an advanced EOB. Have you ever heard of an EOB, or explanation of benefits?
No.
So if you've ever used any healthcare services under your health insurance, mm-hmm. You go to the doctor, even if it's just a doctor office visit or a prescription drug. About a few weeks after that, you get a letter from the insurance company, and you'll open it up and it says, "This is not a bill." I don't know if you've seen one of those.
No.
And it says explanation of benefits. So you're not opening your mail. Because I know you've been to the doctor once in the last couple years.
Yeah. Honestly, I will say I haven't.
So look out for it next time you go.
Well, I haven't been to the doctor.
Yeah.
And I think
that's important. You gotta go.
And that's one of the things I bring up to you is I don't not like doctors. In fact, I'm fascinated by some doctors, and other times I'm worried that this person is a doctor when I've spoken to them.
Be very afraid.
Yeah.
Of some.
There was a conversation that I had. I actually think producer Ben was there, and a doctor told me that he didn't believe our gut biome was important or even there at all. He didn't believe in that. And I'm not a doctor, so what am I going to argue with this doctor?
Yeah, right?
But in my head, I'm like, this guy's a crazy person. There's so much data and statistics that I didn't have offhand, but I know is there to support evidence and claims that your gut biome is super important to your overall health of your body.
Of course.
And this guy is...
But it's feeding all your other organs.
This guy...
Everything goes through there.
Is saying it's not there. And I'm sitting there, I'm like, I don't even know what to say to this guy. You know what I mean?
Yeah.
And so it goes back to, I think a lot of people are in the same boat as me. It's like, I asked you, how do you find a good doctor? How do you find someone that's honest, transparent?
I'm trying to do it right now, believe it or not. I unfortunately lost my primary care doctor he retired and unfortunately got cancer and could no longer practice anymore. So I had the daunting task about 4 years ago of having to find a new primary care doctor. And I actually called my medical director, Dr. Dorek, and I said, hey, now I'm more conscious of this choice than ever.
Yeah.
Now that I've been exposed to this, like I understand the system,
Yeah.
and so I'm going to proceed with caution. And he sent me to his primary care doctor.
Yeah.
So I was like, okay, if this is the primary care doctor of the doctors, and he's a specialist, then I'll go see him. And he was extremely thorough. I was extremely impressed. Especially, all the testing that we went through the first time that I didn't see my old primary care doctor did.
Yeah.
Right. And so I was like, okay, they're more thorough. He's asking the right questions, right, of me in those interviews, because it's really like an interview.
Right.
Is he spending time with me or her? Listen, female physicians have some of the highest and best quality ratings out there, especially female surgeons. As a matter of fact, my brother who got the cancer, his rectal colon surgeon is a female, and we had the choice. He came to me, and we coached him through this. I brought Dr. Dorek in, and we went through a series of doctors, and the top doctor we found, she was female, had the highest ratings. And if you correlate women surgeons and treatment doctors, they have higher quality ratings than most men. Not that men don't have
why do you think
great
that
quality
is?
ratings. A lot of that's been asked. It's been asked, and a lot of people think it's just the correlation of the thought process of the motherly nature of
that makes
females
sense.
trying to take care of people. That they're more nurturing.
Yeah.
They take their time.
That goes back thousands of years.
They're worried more, which goes back thousands of years, right? The motherly feeling of an infant, right?
Yeah.
That maybe it's that. I don't know, but a lot of people have said, they're just more patient. They take more time. They're more thorough. Not that there's not great male physicians out there that don't have those skill sets, but on average, that's what we see. Some of the highest rankings are out of females.
If the biggest takeaway from this conversation we're having is that higher cost in healthcare absolutely does not equate to higher quality or good quality for that matter. Is that the same in other countries? Have you looked at any studies that look at the world healthcare systems?
Well, it's very different outside the U.S. And I don't know the statistics off the top of my head, but we spend more per patient on any other country, and yet we're the unhealthiest.
Yeah. And we're only one of 2 countries that allows pharmaceutical advertisements and to direct to consumer as well, which is insane.
Clearly, look, and we pay more. The U.S. government's allowing us. Look, they're cracking down on it now. You see there's a lot of pushback. They brought the drug companies in to testify in front of Congress because we pay more for drugs in the U.S. than our counterparts outside the U.S.
Yeah. What's very interesting is I saw a post on X the other day, just so everyone knows, we were recording this on November 12th. This episode is going to air in a couple of weeks. But apparently, and there's not a lot of data or evidence to support this claim that I found. I also did not dive into it, so I'll preface it with that. But apparently, there are secret meetings happening with the pharmaceutical companies' executives because they're worried about Trump. They're worried about what is he going to do? Is anything going to change?
And that's why I think the TICRA law was under Trump.
Yeah.
And that probably, what else was going to happen? What else is he going to let out of the box on our business secrets?
Right.
Right?
Right. It's crazy. This is just it's all so crazy to me. And it's one of those things that saddens me. I think when I look at this, it just, like this morning, I'm watching this while I was shaving and getting ready and eating breakfast. And it just saddens me that we sit here in a country where we claim we're the best, we do everything the best way possible, yet our medical system is price gouging consumers. Doctors don't even know that. I would say that doctors are not even aware that this is happening to the extent that it is. Do you think that's a fair claim?
I think it's fair. I mean,
I mean,
the doctors are They're on the front lines in the hospitals. There's administrators that sit up in the executive suites
Yeah.
that are articulating how a for-profit hospital can make the most money.
Can you show the audience some more evidence about how cost does not equate to good quality?
Yeah, absolutely.
Because I think it's really, some of the stuff that you have it's really special to be able to understand. Words are one thing, but when you look at data, you look at statistics, you look at charts, you start to really get a grasp of this and see how detrimental the system is to the consumer. And I almost hate using the word consumer because we're humans at the end of the day. And that's what it's all about. Let's talk about something that could change the way you handle your money. Imagine a world where your bank account is as fortified as an armored truck. Welcome to the Brinks Armored Account, the last debit card you'll ever need. With at least one monthly deposit of $500 or more, you can say goodbye to monthly fees and hello to money management that pays you back. With the Brinks Armored Account, you get cash back on your purchases, access to over 100,000 ATMs with one free withdrawal per month, and an optional overdraft service that respects your boundaries. But that's not all. Brinks takes security as seriously as you do. Enjoy peace of mind with ID theft protection and purchase assurance, guarding your transactions and new purchases against damage or theft. It's not just an account, it's an armor for your finances. Qualify for early direct deposit, and you can receive your paycheck or government benefits up to 2 days faster. It's your money. Why would you wait? Step into the future of financial confidence with the Brinks Armored account. Visit brinksarmored.com to learn more or connect with Brinks Armored on social media. Brinks Armored account. It's not just safe, it's Brinks safe.
Yeah. So, you had asked about quality and cost, but let's just talk about quality for a second. These are misdiagnosis rates: 20% cancer, spine surgery, 67%. Look how high that is. And musculoskeletal surgery is some of the most expensive. Can you imagine? We've stopped patients that were sent in for, one of the most expensive surgeries out there today is spinal fusion, right? Cost is huge, but you know how many times we've stopped a spinal fusion surgery from happening? And when I say it's expensive, I mean, you're talking about a surgery about $180,000 can be upwards of. So imagine you go to your doctor and remember, you're in a for-profit system.
Yeah.
Hey, we could fix this with a spine fusion. Do you really need it, or do you don't? I personally was told by a physician that I needed a hernia. I have a herniated disc in my back. Surgeon absolutely said that I needed to get surgery. It's been 3.5 years. I haven't had surgery.
And you're
and
okay.
I feel great. Yeah. I had a bad sciatic, went in, they saw it. But this is what I'm getting at. If you could stop, think about that. If you could, you're doing so much for a patient, number one, not having to cut them open because of recovery times and all of that. That's one thing, is does this really need to be done, right? And then the fact that you caught it and it really didn't need to be done, you just stopped maybe a $180,000 claim from hitting the employer, right? Versus no healthcare supply chain management. Letting the person go in on a fully insured plan, doctor says, do this, doctor knows best, and you just had $180,000. Yeah, you hit your maximum out of pocket. You paid your deductible, your coinsurance. It was costly to you. Even more costly is your recovery, right? Especially, right, if after that you now go on pain pills that you maybe get addicted to.
Right.
Or the fact that you had that surgery makes you become partially immobile for a certain amount of time. And in that loss of mobility, you gain 20 pounds, right? And now develop another condition later down the road, like diabetes, because of that surgery you never needed. So one of the things we do today is, if it's a musculoskeletal surgery, we'll actually require, at least I do this with my clients, I require that it stops there. And those medical records need to go to a specialist team for a second opinion, right? And I can buy that second opinion for about $1,000. from 5 medical experts, and all they do is spinal fusion. And they have no horse in this race.
Right.
They get their $1,000 as consultants.
And that's it.
And I get it back from 4 of them. And either all 4 of them confirm no back surgery is needed, do rehab, and this would be the protocol. Or maybe they disagree. One of them says yes. At least you can take that back to the patient and say, wait a minute, before we do this, I have a 3 to 2 that you don't need the surgery. 2 say you do, your doctor, 1 of our experts, but 3 of the other experts say no.
Right.
Do you want to hold off? Should we jump into this right away, or do you want to try the rehab? Right? See if you can get yourself on the foot. I actually considered that surgery. Thank God today I did.
Yeah, thank God.
Yeah. So talk about misdiagnosis rate, orthopedic bypass surgery. Look how high that is. Cardiac stents, organ transplants, even organ transplants. It's kind of fascinating. So we talked about cost and quality, and this is the biggest misconception. And this slide here will show you the professional services. So that would be the surgeon or the doctor. So this is a total knee replacement in the market, Fort Collins. And the teal color is your surgeon. That's the cost of the surgeon. And you notice how there's not very much variation in the cost the surgeon's paid. We saw other things where illustrations where a CT scan was 1,600%. So here, most of the doctors are making about the same amount of money. And in the dark blue, you'll see that's the anesthesiologist's costs. Again, very relative variance there, not much, right?
Yeah.
But where we see the huge variance is in the orange. And the orange here represents the facility, the cost of that facility. And you'll see that the cost of the facility represents typically at the lowest 75% of the cost, okay? And upwards of way more than that. So this shows you that one of the facilities at the bottom, you could have this surgery just under $20,000 for about $18,000. But this is all the same market, mind you not. So you're talking about a market, these hospitals could be 5 miles apart from each other, these facilities here. So, and then at the top part, you'll see that the surgery can get up to $100,000 for this type of knee replacement, depending on where you go, and what's driving the cost is the facility.
Crazy.
Okay? Not the physician. And listen.
And there is nothing that's different in these pricing models besides facility.
Correct.
It is the exact same procedure. It is just where you're getting it done.
We ran the CPT code. So this is a bundled service CPT code.
It's insane.
And it's going to reflect that. So you'll notice here, and by the way, you may find that surgeon that's represented by the teal color works in the hospital that's $100,000. They do the surgery there. And then I would guarantee you that the under $20,000 is an ambulatory surgical center, which, by the way, is going to have a lot less of an infection rate. And you're probably going to get a higher quality surgery there because it's an ambulatory surgical center. And I know that physicians practicing with their team, not the team that the hospital administrator assigned to them for the day, which could be a completely different anesthesiologist, probably somebody they maybe never even worked with before, right? In that day. So that's a huge difference. And so the next slide, this will be fascinating. Here, we get to the quality. So this is what happens when we plug in quality. So the red is low quality, the yellow is average quality, and the green is high quality. And you'll notice here that the 2 that are the lowest quality at $100,000 are the most expensive. And look at that, the one that's under $100,000. I even told you in the slide before, I bet it'll be high quality, not just because I've seen this a million times. But if you gave me this data, I've seen it so much that I could tell you on quality rankings where you would end up. But that's the highest quality you're getting at $18,000.
And is it 99% of the time? Is it 100% of the time that we're seeing that the higher the cost, the worse the care?
It's not. You can find high quality care at high cost, which this will tell you. Right. You see, it's just under it. You have 2 green lines that say, hey, these are high quality facilities. However,
the cost
they're charging.
Yeah. You have that same green line down there, 20,000, a little less than that.
100%. So how does that impact a company, right? So a company that's paying for this knee replacement, right? So let's say I'm the company, you're the employee, you're going to have a deductible coinsurance because this is an outpatient surgery. Okay. It's going to be most likely be subject to some sort of deductible coinsurance or a higher cost to you, per day in the hospital. So you're going to pay for that. And then me as the employer, we're going to get hit with a claim, or the insurance company is going to get hit with a claim. Whether it's the insurance company or the employer, if it hits the insurance company, it's just getting passed down to the employer, right? In that loss ratio. Hey, we need to charge you more this year because for every $1 you paid us, we paid out $1.50. Right? So
either way, it doesn't matter.
By the way, here's my incentive and my excuse to go, okay, this year we need a 40% increase in your healthcare costs. And then the next year, once they gave you that 40%, you ran at a 60% loss ratio. They just made all that money, right? Yeah. And they justified it by one bad year prior. Okay, so you get into that and you start to look at this, and this is where you say navigation is huge, right? So I want to get to this patient right away, especially if I come in and I look at that and say, oh my gosh, they're going to the top line. Terrible quality and high cost. My conversation with the employee is not the high cost, it's the quality. That's how I'm going to get you to move physicians.
Of course.
I'm going to bring the data to you and say, hey, this facility ranks here, right? And by the way, you can go here, and this is a top physician. And by the way, your employer is willing to give you $1,000 or give you $2,000 for using this provider. So the employer just put up $2,000, right, to save $80,000. That's a good business proposition for them. I'm going to come to them and say, hey, and we create a reward system behind it where everything's shoppable. If it's below the median cost, they share in the savings. They share in the cost savings with the employer. So if you can do that and use an incentive, right, high quality, and wait a minute, this is going to be subject to my deductible, but you're going to give me $2,000 of that deductible if I use this doctor over that one. Yeah, well, maybe I'll listen to you, and I'll change doctors, and I'll use this physician for the surgery, and I'll reduce now my out-of-pocket expenses as an employee, which makes me super happy. My healthcare costs are going down, and my employer's healthcare costs are going down, which means next year it helps everybody's healthcare costs stay down.
Yeah, and I'm shaking my head a couple of seconds ago because it shouldn't be this complicated. It shouldn't. It should be straightforward. No. It should be, you need a procedure, here's where you're going to go. You could see very clearly what the price is. I mean, the difference in pricing, $100,000 to what is that? $18,000. I mean, that's
about 18.
That's such an outrageous difference in price for the same procedure. And you're getting worse quality versus the best quality.
100%.
And I just can't fathom it.
But remember, think of the dynamics you're dealing with. So I just told you earlier, I said, if I walk into a room of employees or anybody and I say, wait, what do you think good healthcare is? Your answer 99% of the time is that I can go to any doctor I want to. Me on that, I don't want you going to any doctor.
You want to go to the best.
I'd like to tell you, hey, you don't have a choice. You need a knee replacement. This is the facility in your county or you're in your city that you're going to use, and this is the doctor you're going to use. But all of a sudden, you're going to be mad at me. I can't go where I want. This is restrictive. You're doing this just to save money. No. We're doing it because we're sending you to the top surgeon, and we're going to pay a fair price for it. And we're not going to allow our company to get ripped off, and we're not going to allow you to get ripped off.
Yeah.
And so this is where you see those dynamics collide.
Yeah.
Right?
I know you said you've testified before Congress. Was it related to this?
It was a congressional committee, an offset committee.
Okay, but it was related to this? Or
related to this, yeah.
And what was the reaction to that?
They all know it exists. The problem is they're letting the lobbyists write the laws, and they're taking influence on that, right?
Yeah.
And that's the kind of the system we have in America.
Well, we could overturn that, though, couldn't we?
We can. And by the way, TICRA did that. It took the first shot in this direction, right? To say, and look, this is great for American companies that this stuff is, lowering healthcare costs and healthcare costs in a company is either your second or third largest line item.
100%.
Okay, it is.
100%.
And the one that nobody's optimizing, right, in their company.
Yeah.
Can you imagine?
Because you feel like your hands are tied behind your back.
You do.
Because there's no Chris coming and telling you these things.
You feel like you're and the Chris's are still brokers. They're not advisors anymore. They're misaligned incentives to sell you high commission products. And as those products increase in cost each year, well, so does my income.
Of course.
And so who's really going to tell you what's going on?
No one.
Right? And so that's really the secret. So TICRA was the first shot, and now you're starting to see, them attack the drug companies and the PBMs, the pharmacy benefit managers.
Yeah.
Why are we paying more? But one of the things that we do in advance of this is we'll source medication outside of the country for our employers and their employees. And I'll give you a great example of it. It wasn't an employer, but we do it every day for employers. You can source drugs out of Canada. There's certain markets you can, and bring them in and pay 1/3 of the cost that you would purchase it for in the United States. And a great example is my mom was just she's diabetic, and they're giving her Ozempic. Should I wait for that?
No, you're fine. You're all good.
My mom's diabetic, and she was given Ozempic. Okay. We finally getting Medicare to pay for it because that's coming around, but you have to hit certain criteria. But at the beginning, Medicare wouldn't pay for it. Actually, the stuff she's on right now wasn't paid for by Medicare. I actually purchased it in Panama. I was down there in Panama and staying at a hotel. I was down there for work. Actually, some of my care navigators, was down there training them, are out of Panama, which are great navigators. And I was walking by and saw the pharmacy, so I decided I'd walk in because I was trying to get the Ozempic here, and Medicare wasn't paying for it. My mom's 73 years old, and so we were cash payers of that. Okay, and I think the double dose, when I checked here for that, was about $800 a script for a double dose. Walking by the pharmacy in Panama, I was talking to a buddy of mine, and we had just left training our care guides, and so healthcare was on my mind. Wait, there's a pharmacy. Let me go in and see if I can get Ozempic. And I ended up walking out with a same dose, double shot, $250. In the U.S., I'd pay $800 for it. So I bought 2 of them for her. And I flew them back and I gave them to her. And she just started them literally like 2 weeks ago. She just started them. But I was able to source them down there for half the cost. And that's what's starting to happen now is people are starting to ask those questions. You're starting to see why are countries paying, France, why are they paying 1/3 of the cost that U.S. citizens are? And we invented the drug.
It's crazy. It's crazy. It's because they're price gouging.
A U.S. company invented the drug, and our people pay more for it versus the opposite, right?
It just makes no sense because as the consumer, as the human being, you would think that healthcare is something that's gone through with a fine-tooth comb, that we're making sure all the T's are crossed, all the I's are dotted. But at the end of the day, if the regulators aren't regulating, the job is not being done correctly. Mm-hmm. Things are going to fall through the cracks. And this is the bullshit that's going on is this.
It is. And the regulation sucks. Okay? Wall Street works because they got the SEC and they got great regulation. It breaks down sometimes. Though, but all capitalism breaks down sometimes.
Of course.
I don't think that having a for-profit healthcare system is bad. Yeah. I think it's great. I think it creates competition. It just has to be transparent.
Right. So if I were to say, Chris, if you were to start a country from scratch and put together a healthcare system, what would that healthcare system look like?
It would be for-profit, but completely transparent. You have to know the price of things before you purchase them. And not knowing the price of things before you purchase them is what has sucked all the money out of the room and all the wages increases out of the room and created massive profits for large insurance companies. Okay? It's okay to profit in a capitalistic system, no doubt. But make it transparent and fair to the consumer.
Yeah, but if we were to do it that way, right? And let's use that example of the $17,000 X-ray, chest X-ray, right? If you were to get that, how would the consumer know that that price is wrong, that that price is too high? If you were to see, and let's say they're using the price gouging method that they're using today, and someone's walking in, Chris is walking in, getting a chest X-ray, and okay, $17,000. Well, how do you know that number is so inflated when the real cost should be $5,600?
Consumerism, right? If you're going to purchase a car today, right? You know the make and model of the car you want.
Mm-hmm.
You know the CPT's code of the MRI you need.
Yeah.
You call a couple dealerships. You go online, right? Okay, this dealership has it at this MSRP. This dealership has it at this MSRP. And they're the same quality, right? But they have different costs depending on where their dealership is.
Right.
Right? A lot of times. Same thing in healthcare. We need to teach that same consumer to use the same consumerism they use in every other part of their life in their healthcare, because there are apps today where you can go in and see this. Talent Healthcare, Healthcare Blue Book. You can go online. You can call providers. Hey, how much is this under the cost with the insurance company?
Yeah.
So it's there, and then make it easier to use, right? That's really the key to it, is drive more consumerism into the product. Make it transparent, easy to use. Providers must show their cost. Just as you go down to the dealership, you see the MSRP before you make an offer or buy the car. Same thing. I walk into the provider's office. And by the way, TICRA will bring that transparency into the provider's office. Today, we're using the insurance carrier apps, some of these other third-party apps to do that. But when it's fully integrated, and we can actually walk in or call a doctor's office, you can do it today. On cash pay, you can call 3 different imaging centers and find 3 different cash pay rates. Okay? But when you call and you say, I have XYZ insurance company, how much is the MRI here? Right? They should be able to tell you what the contracted rate is. Our contracted rate's this. Now, the other part is structure. Does your are employee benefits structured correctly?
Right.
See, I would never, now that these tools exist, I'll give you one line item I would never allow happen in an employee benefit plan I sold one of my clients. I would never allow you to have a copay. Actually, I do allow it. I allow it by force. When the employer says, no, I want this. And I say, well, you shouldn't do that. Well, why?
Yeah.
Okay. Sometimes the customer's right.
Yeah.
And how far are you going to push before you make your customer angry? But that's the other part, is there's a lot of advisors out there that aren't trustworthy, that they've created, the word broker has bad connotation. I was at a conference, an HR conference, and I could hear HR, I don't trust my broker. You ask, how much trust do you have in your broker? And the reason is the misalignment of incentives to sell high commission products, right? So getting back to that, it's really the aspect of the copay versus coinsurance. And I'll tell you what I would never allow the business owner to leave a copay for diagnostic services, MRIs, CAT scans, or PET scans, because it's terrible for them as a business owner, and it's actually terrible for your employee as a business member. And I just saw it the other day. Company went into $300 copay for imaging. Okay, so if it only costs you $300, why would you shop it? You won't.
Yeah, of course. Yeah.
Okay? But what if I told you, and there's your misconception, the employer just let you overpay by giving you a $300 copay, and you may think it saves you money, and maybe it does,
I see,
depending on what provider you're going to.
Yeah,
you
I
with
see
me?
what you're saying. Yeah.
So what if I showed you that you could buy that for $180? So here's what happens. You're going to walk in with the $300 copay, and you're going to sit at the provider's office, and they're going to take your insurance card and they're going to say, Mr. Leap, this is a $300 copay today. And you're not going to argue over the cost. You knew it was a copay. You knew how much you were going to pay when you walked in. And you say, hey, here's the $300. You go home. 2 weeks later, that explanation of benefits comes to your house that we talked about.
Yeah.
It tells you how much your insurance company paid.
And that's where the prices are not accurate.
And there you go. And you start to look at it, and it says patient responsibility, $183. Well, that's the contracted rate, $183. Well, I gave him a $300 copay. Go back and try to get that money back from the provider. You just overpaid.
It's insane.
Because you paid the $300 copay, and the patient responsibility, because they're not going to let the provider's only entitled to the contracted cost.
Right.
If the contracted cost is $183,
So they're just literally lying to see if they can get the $300.
well, they're not lying. Usually the person behind the counter has no idea what the contracted rate is.
Right. It's
They may
not the messenger.
You got it. Don't kill the messenger.
Yeah.
But I thought I was giving you a great benefit as an employer. Hey, it's only $300, and maybe I was if you went to the hospital to get it done, and you were paying $2,800 for the chest CT scan, and you only paid $300. But guess what? It meant your employer paid $2,500. So what did I just do by putting that copay in that category? Some brokers will sell that,
right.
And I say this is terrible. You're killing the employer. You're doing a couple things. You're disincentivizing the shopping, okay, which is going to cost you as the employer to pay more money. And your employees are likely to overpay at a few facilities if they go to those lower cost facilities.
Right.
Why not introduce consumerism in this line item? Hey, it's subject to your deductible coinsurance. Now you have an incentive to shop it.
Yeah, but to play devil's advocate for a second, on the employer side of things, the employer, if they're getting the $300, they don't care to shop it, like you said. The money's coming to them either way. It's not their money. They don't care. How do we do a better job at educating the employees that, yes, this might be, using what you always say, your insurance card is a black Amex and you can go and spend whatever. Okay. How do we get the employees to understand the trickle-down effect? Is that having someone like yourself come in and speak to them and understand, hey, even though it seems like you have unlimited funds, it's still going to shoot you in the foot later on, whether that means you're not getting a raise, whether that means the cost of the healthcare is being put more on you than ever before. What do you think the best message is to the employees?
The message is you got to set up the health plan correctly to create the incentives. Incentives can be carrot or stick.
Yeah.
Right?
Yeah.
So where are the incentives? Did you set up the health plan from the beginning to be maximized in its functionality?
Yeah.
Is it optimized? And in giving you a copay for that, I have not optimized that. And the trickle down I'm not worried about. It happens naturally if I set the benefit plan up right to teach you how to save money on healthcare and reward you when you do save that money.
Yeah.
Like, share in the savings.
Yeah.
You see,
yeah.
if I said, hey, and that's why we use those rewards and a median. If you used let's just say $100 to $1,000, let's call it whatever service you want. Service 1. That's the CPT code. Okay. So you need service 1. And the range on the contracted rates with the insurance company is between $100 and $1,000. Well, I say if you use any provider below, let's say the median is $550.
Okay.
If you use any below $550, any provider you use, you'll get a reward. You'll either get a cash check, right? Or you'll get HRA rewards to reduce your deductible, right? For current or future medical expenses. And you share in that good behavior, you're probably going to use that,
right?
Especially if you used it once and said, wow, this really worked. I got high quality care and I just got a check from my employer for being a good consumer.
Right.
You see?
Everyone's going to win.
Then everybody wins, and the more and more employees start to use that. But that's a sustained period, and that's why I get into you need to have a 3-year, 4-year, 5-year plan. Because if only 30% of my employees statistically use healthcare in 1 year, I've only taught 30, if you had 100 employees, I only taught 30 of you in the first year and maybe less how to use this. Right. Then the next year comes, I'm getting a different 30. There's some overlap, same 30, different 30. Yeah. By year 3 or 4, I've probably had 100% of the employee population go through me. That through shopping and navigation of the experience. And now in year 3 or 4, you're running seamless. Like your health plan, your loss ratio's down. You can go self-insured, save 20, 30% on your healthcare costs out of fully insured to self-funded. And you have a consumer-driven product where everybody wins for good behavior.
Right.
And you have to set that incentive up from the beginning. And that's just the key to it. It's the benefit design, the rollout.
Right.
And having a long-term plan, not I'm a broker. Here's your choices this year. Let's not do anything about it. And by the way, you can't do anything about it.
Yeah.
I want you to think you can't do anything about it.
Yeah.
Right. And that's the typical
And you're
aspect
shoved
of
in a
way.
corner,
You're shoved in a corner,
hands behind
and
your
that's
back.
it. And then two, one of the other aspects, you have a real misalignment a lot of times between HR and your CFO and CEO, of
course.
right? That are looking at EBITDA and the bottom line.
Yep.
And so they're looking at EBITDA and bottom line, and HR directors thinking, hey, I need one of these big names on our ID card.
Yeah.
I need the Prada. I need the Gucci on the ID card so I can go retain and attract high quality employees.
Yeah, such a backwards way of thinking.
It's such a backwards way of thinking.
But that's only backwards to me because now I know.
You know.
Now I know.
You got it.
Before we had this conversation, before I watched your documentary, I felt the exact same way.
Yep.
The exact same way.
Yeah. I can show
need
you higher
the
quality
bigger
care
name.
outside of those big box names than you ever see inside of them.
Yeah.
Because I can control the healthcare supply chain.
And that's why the
I can
education is so
intervene if you're
important.
going to a bad doctor.
Yeah. Yeah.
Right. I can show you the cost of what you're going to spend or
Yeah.
might spend.
Yeah.
Right. So believe it or not, those things, while they're frowned upon by the employees because, right, they think we're driving them to low cost,
Yeah.
which means low quality. You have an HR director who thinks the same, that he or she needs a big label on that card to attract and retain employees. And then you have the C-suite that's thinking the opposite. Hey, our healthcare costs are skyrocketing,
Yeah.
but every time I talk to HR, it's like, no.
Yeah. Yeah.
We don't want to touch this,
Yeah,
right?
yeah, yeah.
So there's those dynamics internally working in your organizations as well.
It's crazy.
It's so those you got to break that normal way of thinking.
Yeah.
You got to teach the C-suite and the HR, hey, we can deliver a higher quality of care at a lower cost point, and this is how we're going to do it. And we're going to start with, first of all, aligning everybody's incentives in the room, so we're all moving in the same direction, right? And then we need a long-term plan because it's just not going to turn overnight. Yes, you're going to get some savings,
Right.
but as you consistently stick to this game plan of healthcare supply chain management and you implement these point solutions, you will see your healthcare costs start to level out and really take a different direction in terms of quality and cost.
So before I take the conversation into the next avenue, I'm going to pause for a second and use the restroom real quick. More and more people are starting to become concerned about their plastic waste. That's why having a fun, refillable water bottle has become such a popular trend. So let me introduce you to our official beverage sponsor of the Best of the Best podcast, Path, a sleek and completely recyclable aluminum water bottle that is also BPA-free and refillable. Refilling your Path bottle not only reduces plastic waste, but also contributes to becoming carbon positive after only 4+ refills. Since 2015, Path has been on a mission to end single-use plastic. It's not about drastic changes. It's about simple lifestyle switches. By educating people and encouraging them to #refill it, Path shows that every refill counts in the fight against plastic waste. It's a small step that can make a huge difference. You can find Path in over 55,000 retail stores worldwide, including stores like Whole Foods, Target, CVS, Sprouts, and many more. Path is also present in airports, gyms, schools, and has extended its reach to travel, fitness, national parks, hospitality, and healthcare sectors. To learn more, visit drinkpath.com or follow them on Instagram @pathwater. Now, let's jump back into the episode. Ladies and gentlemen, we are back from our bathroom break. I want to talk about the solutions and how we can come together to create change. What is the best way, whether a business owner is listening right now or a consumer is listening right now, that we can create change? How can we do it?
The change is already underway. There's just no doubt about it. There's a massive transformation in the system. Number one, the TICRA law has helped.
Yeah.
The fact that Congress is now looking at pharmacy benefit managers
Yeah.
to try to curtail those costs. But the solutions, look, most of America gets their health care through Social Security, Medicare. right? They're the largest consumers of it. The rest of us get it either individually on an exchange or through our employer, right? And where the real abuse is happening is at the commercial level, at the employer level, or the individual level, right? Because we know Medicare is paying 100% of what they deem they should pay. They dictate, right? They get to, the government just gets to come in and say, we're going to pay you this, and
That's
it or
it.
not like it, charge the commercial guys whatever you want, but we're going to pay this, and you're going to honor it. Okay, so
And just to make sure I understand correctly, and I'm going to take us off track, but it's important. That number that the government is willing to pay, everything else is based upon being reasonable, quote unquote, to that number that the government is willing to pay.
correct. So the in the ACA or Obamacare, it says that providers must charge a reasonable fee for that. Well, a lot of us, and going off track with that. So what does that mean, right? How can I challenge a reasonable amount? Well, if most of the U.S. pays Medicare prices, because that's the largest consumer of healthcare, right? Well, that would be the most frequent charged, right? Applied to that service, right? So think about, and we had talked a little bit about this concept called reference-based pricing, okay? Where an employer uses no medical network anymore. They go in and negotiate every cost of every service for their employee. They say, hey, where do you want to go? And then they have a separate point solution company come in, call that provider, and say, hey, dear provider, these are the CPT codes our patient needs. Let's just say it's a knee arthroplastic surgery, right? Here's the CPT codes. You normally pay Medicare, or Medicare normally pays you $10,000 for that surgery. We have the same patient, needs the same surgery, but instead of paying you $10,000, we'll pay you $14,000.
Yep.
So 40% more than Medicare.
Yep.
The provider usually says, yeah, and you'll pay me quickly, like in 7 days? Yeah, we'll pay you in 7 days, 140% of Medicare eligible. I love it, okay? This is the way the health insurance market should work, going and negotiating that. Where it falls and where this gets difficult is in an emergency room stay. It's not planned.
Yeah.
So most surgeries are planned, right?
Yep.
But now you have an employee that's rushed down in one of these models to the emergency room. There's no network. The emergency room gets the card. They call in and they say, yeah, they're covered. The deductible's $5,000. Charge them that. Member pays their $5,000. They're admitted into the hospital. The employer has no contract with that hospital. Okay, so they're just gonna, what would normally be contracted at maybe, if it was a serious condition, and let's just say it was $100,000 normal hospitalization for something, sepsis, that what have you, but all of a sudden the patient gets home and they get a $400,000 bill. Okay, immediately an employee freaks out. I got a $400,000 bill, right? And probably the contracted rate, if you had a contract with that hospital, may be $100,000. Okay, Medicare may be $30,000.
Yeah.
Okay.
Yeah.
Okay, but if you had a major insurance contract, you'd pay around $100. But that the unsubscribed cash rate, meaning rushed into an ER, they're billing you $400,000. So now you're in a fight with the hospital administrator. Right? Hospital administrator is now sending bills to the employee, bills to the health plan that the health plan's not paying. You owe us $400,000. So here's where the health plan can push back, based upon that caveat of a reasonable price.
Okay.
Okay. So, and we haven't seen many of these challenged, and most of them settle on equal sides of this seesaw. And what I'm going to get at is, one side is saying, dear hospital administrator, what do you think is going to happen when you file a lawsuit against us and we go defend this in court in front of jurors? And we go in front of the jurors and say, hey, here's the law. The law says that you must charge me a reasonable price. Okay? And Medicare pays $30,000 for this, and you accept it. As a matter of fact, you accepted it for 350 patients last year on the same knee surgery between all of your hospital facilities. Okay? You accepted 30,000. Now my member comes in and they should pay 400. How is any jury of 12 going to say that's reasonable of a charge?
Yeah.
And do you think that those peers are going to agree with that individual sitting behind there or that business? Or do you think they're going to side with the major insurance company?
Right.
And or the major hospital chain that's trying to rip you off?
Yep.
I don't think that that's coming down. And so typically those types of things get settled out. Okay?
Yeah.
And that's where the friction of what's called reference-based pricing is, which is really bringing the best consumer model back. You need something, let's call the administrator of the hospital. This is what I need. You accept this price all the time. I'll pay you 40% more. So now what happens is the employer is paying on average 140% of Medicare eligible for their services versus most of these rented networks that we go purchase that are at 250% of Medicare eligible under those contracts. And so each of those services, what am I doing? Supply chain management, healthcare supply chain management.
Yeah.
We're just not going to let you go to any surgeon. Right?
Is that Medicare cost the same across all hospital systems, or is it?
It's standardized. It's not the same. So they're attached to CPT codes.
Okay.
And for instance, I don't know if you've ever heard of critical access hospitals. So
I don't think so.
Access hospitals will get all types of special reimbursements or funding from the government.
Okay.
And what they are is remote area hospitals.
Okay.
Where without a hospital in that area, people would be dying, right? Because there's no place close.
Yeah.
They're the closest hospital for 50 miles. If that hospital closes, the next hospital's 200 miles away. We can't have that in America.
Yeah.
You get it? Mm-hmm. You can't run a city. Cities would be like, the closest hospital from our city is 100 miles. That's terrible. How are you going to... So these are critical access point hospitals that are funded by the government. So they will... or their shortfals are.
Okay.
To make sure they can stay in business and the doors stay open and that they're reimbursed. So it depends on the region of where you are. I mean, Medicare eligible is pretty standardized, but it can be based upon the region that they're in, obviously, because there's more costly regions and critical access has.
Got it.
You got it.
Got it.
So it's a little bit broken up in that. But when you can start negotiating these things up front, right, the disadvantage you have on an ER is you're negotiating in the rears, right? And that's where it could get legal. Well, you came in my restaurant, you didn't look at the price of the menu, and you ate everything on the menu. Here's your bill.
Yeah.
Right?
Yeah.
Versus, having a contract or, hey, I'm coming into the restaurant. I realize that, the chicken cordon bleu you normally charge government employees $10 for because they get discounts. I only want to pay $14. Okay, come on in. We'll feed you.
Yeah.
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 We'll feed you.
Yeah.
So they'll accept that. And so that's becoming a huge thing right now, is reference-based pricing for employers, especially large employers. They want to go negotiate these things up front.
Of course.
Right.
You're gonna save money.
You can save that money, and huge, by negotiating up front and not having a contract in place. But where it gets sticky, again, is that it's a little bit different of a process, right? For the employee. Employees getting threatened by the hospital, doesn't realize the employer has to cover it at the end of the day. And listen, in some of those cases, it doesn't settle out at 140% of Medicare eligible. But what if I told you as a business owner, look, every once in a while, we may have to pay 200% or 240%, but you're paying what you would have paid if you had a contract in place, right? So for the one or two times I can have that happen. So let's say I have a large company, right? Thousands of employees. And let's just say we had 35 surgeries that year. Okay, 2 of them were ER visits. Okay, emergency surgeries. Okay, but I was able to negotiate out of the 32 surgeries, and 30 of them I was able to negotiate at 140% of Medicare eligible.
Yeah.
And these last 2 that were ER visits, where the hospital administrator really resisted me. There's a local hospital here that has a monopoly that really resists this because they don't want to start a domino effect of having to accept it and get their name out there that, hey, we're really accepting this.
Yeah.
Okay. And so they push back on those 1 or 2. They say, you know what? 140% of Medicare eligible. That's terrible. No, we'll pay us full price, full cash price. Okay, we'll offer you 180%. No, you're going back and forth.
That's so crazy.
And so you're just timing them out, right? It's like a whole credit game, right? You owe the money. Well, we don't want to pay that. You know you're going to settle somewhere because they don't want to go to court and have that argument in front of a jury of 12.
Of course not. They'll lose every single time.
They're going to lose every time. So you're kind of like negotiating, and then finally you get it settled. Okay, here's where we're going to settle at. Maybe it's 240% of Medicare eligible because you had a really tough hospital chain or provider chain that was really sticking it to you, and they were really holding their, they dug their heels in.
Yeah.
We're not going to allow this to happen. We don't want to be known as accepting reduced costs.
Do they have to accept, or can they say no in general?
They could say no, you owe us the full amount. And then, okay, come collect it.
But even on the full amount, let's say you want to pay the full amount, can they reject a person because they're a private business? Can they reject care?
No.
Okay.
No. That's the other part. When you walk into a hospital, they have to do the care.
That's what I thought.
Yeah. So, and we haven't seen that because the system's set up to really, I wouldn't say trick the provider, but tell the provider they have a form of insurance. It's just not the regular form of insurance that they're used to with a contracted rate. Like, hey, the patient's there. We can verify the patient. They need to pay you $5,000. We'll take care of the rest. That's the conversation.
Yeah.
And then the bill comes, and then they start doing that there. But again, most surgeries are planned, right? You go to the doctor, you know what you need. You call a hospital chain and say, hey, you do this every day for $1. I'm going to give you $1.40. Will you do it? Yeah, we'll take it, and we'll pay you in 7 days. I love it. And the providers like it because they're not waiting for an insurance company to audit the claim, adjudicate it. And like I told you, I have a plastic surgeon friend in Washington who does reconstructive surgery for mastectomies, and he's owed $2 million by a major carrier right now that hasn't paid him.
Yeah.
Would he take half of that money to get paid in 5 days? Absolutely, he would.
Are there more of you in this industry? Are there other people looking at this with a big, glass eye saying, guys, look at what's going on here?
There is. There's a select group of advisors out there. One's called the Rosetta brokers who took an oath to obviously realign their business practices with that of the end user of it, being the business owner,
right?
To do things right and realign what they're doing and how they're consulting and how they're approaching this.
I think what's fascinating that I didn't even think about until we've been talking is that you guys are changing the industry. You guys are the force. When I say you guys, you and whoever these other people are that have the same method as you do.
It's private healthcare reform.
100%.
That's what it is.
But no one's talking about it. That's why when I'm sitting here talking to people about who I'm having on, it seems like a boring topic at the surface.
Yeah.
But at the end of the day,
health insurance,
it impacts everyone. But I just don't hear it being talked about. And
it impacts more Americans more than they ever know.
Yep.
Ever know.
Yep.
It has, because they certainly have higher wages if you had a different system. Number one.
Yeah.
Number two, most CFOs have no idea they have a profit leak. None. That they can improve EBITDA. They don't even look at it as an line item to go, okay, let's optimize this. Let's improve our bottom line and EBITDA. And they just kind of gloss over it, not realizing they have this huge profit leak out the back door.
Yeah.
First, you have to realize, hey, I got a profit leak here.
So going back to sort of the solutions and what we can do to create a better system and a better environment, it really just comes down to, from what I'm hearing, call you. Figure it out. Figure out what the new way to do it is, because this old way that everyone has been doing for the past 3 decades isn't working.
Yeah.
Isn't
working.
Listen,
and there's loyalty out there in our business. A lot of people have been working with their broker. You and I have had this conversation for years.
Yeah.
A trusted family friend. We grew up together.
Yeah.
And it's not their fault, by the way. They've just been doing business the same old way for 30 years.
Yeah.
And not kind of maybe even caught up that there's a better way to do this now. That there's a better way to administer healthcare. And, you got to first realize you have a problem. And if you don't know the problem exists,
how can you
it's
fix
hard
it?
to fix it.
Yeah. How can you fix the problem?
You got it. And if our brain is, hey, I think some of them have have an idea or they're starting to get it. Like in the first part of the documentary, you saw an HR director saying, this is starting to not make much sense to me anymore. What?
That was a female, right?
It was a male gentleman. It was
okay. I'm thinking of the female that was in charge of New Jersey, or looking at New Jersey government employees. It was in like a courtroom, it looked like.
That was, I think it was Kristen. Okay. Yeah, she's an attorney. She's done state legislative stuff and written stuff. She's very smart in legislative stuff.
Again, just like the reaction of, why is this not being talked about? Why don't the consumers know? Why don't the business owners know? Of course, it's systematically set up that way. There's no denying that. Yeah. There's no denying that. You walk a very fine line. And I respect the hell out of you for this, because at the end of the day, you have to maintain a friendly position with the carriers. They're the backbone of your business, essentially, unless things change. But at the other side of the spectrum, you are calling out the discrepancies that are taking place in the healthcare system. Do you ever worry about your position and what that means? And I'm not even saying worry from a professional standpoint. I'm talking about from putting a tinfoil hat on for a second, from your life standpoint. I mean, you are exposing 20% of the overall economy and what's happening to it, and all these negatives that are associated with it, which damn right should be known by the people. But do you worry?
Sure. There was a level of hesitation in creating the documentary, and conscious thought process. I mean, you're dealing with the wealthiest companies in America, with the biggest fists, and the longest arms and the longest reach. But look, I don't. Everybody involved in this, let it happen, right? And guess, if you're, look, businesses have to be smarter. It's their fault, right? That, look, if you walk in to my store, right, and I'm selling widgets 200% the price they should be, and you don't have the wherewithal to recognize that, I'll sell you the widget.
Right.
Stupid me or stupid you?
Right. Yeah. I mean,
so it really starts with, the system's set up that way, but you've done nothing to attack it, to question it, and I'm questioning it. So I don't know. Are they bad people for? Is it exploitation?
But that's because it's the healthcare system. And I think that's the thing that frustrates me more than anything is we're talking about the system that's supposed to protect the human body, that's supposed to be there.
Not your wallet. I have no responsibility to protect your wallet.
Yeah, but okay, so now you're veering into another argument, though. But just because my wallet is hurting doesn't mean that I'm getting good healthcare.
Correct.
Right? Correct. So that's my point in saying all of this is, if this is just systematically happening, I don't know that you can blame the consumer. I don't know that you can blame the business owner. In fact, I would argue the opposite, because you're dealing with a topic that has been created. You look at doctors. I think this is changing, and I think it's an unfortunate change, because I think you're starting to see less interest in people amongst my age group and even younger wanting to become doctors. The pay is not great. The hours are horrible. You spend majority of your first half of your career in debt. You are creating a system a system was created where we were set up to respect the hell out of the healthcare system. Oh, you're a doctor?
Yep.
You must be smart as hell. You are the guy or the girl, right? You are that person. But it seems like that's not the case.
Well, let's get on this subject matter, because I like it. The quality of care. I just showed you misdiagnosis rates, okay? Yeah. And now we just went through something we haven't been through in maybe 100 years in America, a pandemic.
Yeah.
Okay. I saw this firsthand. My wife was going through nursing school during the pandemic. Mm-hmm. Okay. Mm-hmm. Now she's just finishing up to be a nurse practitioner. Okay. She works at a very prominent plastic surgeon's office here in town right now as a nurse. Within, I think, a few months now, she'll be a nurse practitioner. She'll be able to up her career. But do you realize that she never went through clinicals?
Yeah.
Because of COVID. the hospitals weren't letting people do
Yeah.
clinicals.
Yeah.
So now you have a whole new slew of healthcare providers out there
That have never been in that
that
environment.
never really got 100% of the education they needed to be in that room.
Yeah.
And I'll tell you, for example, for a nurse, very common to do IVs, right? That you'd learn in clinical where to do that. She never learned that. She learned on the job.
It's crazy.
First day. And then
crazy.
hired a special company to come out and teach her because she didn't know. But think of all the knowledge she missed not being in those.
Think about that. She had to
clinicals.
hire a special company
Yeah.
to come and teach her how to put in an IV as a nurse.
Not the school, not the clinicals.
But going through nurse practitioner school. I mean, that's crazy.
Well, now she's in nurse practitioner. This is as a
Okay.
nurse.
This was just as a
but
nurse.
nurses do IVs all day.
Right.
At that level.
Right.
Yeah. So think about that. I thought about it. And I'm like, wow. So can you imagine? We've already, even pre-pandemic, we had all these misdiagnosis rates, but we have all these folks now coming out into this profession, right?
Yeah.
That maybe haven't been as trained as well as they should be trained.
Yeah.
Because we sped up that process, or we needed healthcare advisors, right? And that job, you're right, it's getting less attractive for people. You know, I remember when I was a kid, he's a doctor. It was like God was in the room.
Exactly.
Right? Everybody
Exactly.
bowed to the doctors, bowed to the doctor.
But I don't think that ideology has shifted. It's shifted for you because you live and breathe this every day.
Yeah, it's certainly shifted for me.
That ideology for the common person has not shifted. They still think the doctor
Actually,
is God.
it terrifies me
Yeah.
because I used to walk into any hospital. I've been hospitalized a couple times in my life. One time for food poisoning, 2012. I spent 4 days in Aventura Hospital. I was ignorant to all of this stuff. I almost died. And
What'd you eat?
coming out of that, it was what we believed to be, it was salmonella poisoning.
Yeah.
There's 4 types, A, B, and then C and D, which are the worst. I had C or D. I got a
Okay.
letter from the health department saying I was poisoned. They wanted to talk to me, and they opened up a huge investigation. But it was a cross-contamination on some stone crabs of salmonella
Oh, wow.
at the end of the day. But I would tell you, looking back on that experience, if it happened again to me today, I would be absolutely terrified going into some hospitals. Absolutely
That's so scary to think that someone like you is scared to go in a hospital.
terrified.
It's
Terrified.
just crazy.
Because I know back in 2012, I was getting a much higher quality of care than I'm getting in 2024 on an ER visit or something like that.
And it almost becomes this game of respect. I went through medical school. I did all of this. You didn't do this. Okay, great. But the data and the statistics and the evidence show otherwise.
Yeah.
Right? So your argument that you went through school, great. I'm happy. Thank you for doing that. I appreciate that. But how knowledgeable are you? How good are you at diagnosing a...
Were you a student at a top college?
Right.
Or were you a D student at a university you got, a diploma from a third world country?
Right.
Nobody's asking that question to their doctor, right? And I agree with you. Some of them have God complexes. My wife, as a nurse, questions our child's doctor, our pediatrician, all the time.
Yeah.
As a matter of fact, we got kicked out of our pediatrician's office for it. So we refused certain vaccines for our daughter. I couldn't believe it. I'd like to find out who her name is, but we had a pediatrician in Bay Harbor Island here. And my wife went in, and she wanted to pump my daughters with all of these vaccines. And my wife said, wait a minute, I'm educated. First of all, we don't need to pump all of this all the time, right? There's no polio going around right now. Is there a reason we need to do this now? Or there's no, she had questioned the doctor.
Yeah.
One day I get home from work and there's a FedEx box at the front of my door. What the hell is this? I didn't order anything. Thought maybe I was getting sued. Like somebody sending me, like, what did I do wrong? Or, like, what is this? Or, and so I open up the package and I pull it out, and it's a copy of my child's medical records, the full medical records. She fired us as a patient because we wouldn't fully vaccinate and agree to everything she wanted to do to our daughters.
And could she provide evidence as to why your daughter should have been getting those vaccines?
No, it was the God complex. It was, you don't want to do it. I'm not going to treat your daughter. I treat my patients my way, and my way is it's my way or the highway.
Gosh.
Didn't even allow us to have the conversation of like, this is what we feel comfortable as with parents. We got fired by our pediatrician.
That's so insane.
Because my wife likes more holistic approaches.
Yeah. Which we're starting to see a trend. I believe that's why Trump won the election. Speaking to a lobbyist that I work with very closely, he thinks that silent majority of mothers specifically attached on to Bobby and his movement related to the pharmaceutical industry
100%.
and everything, and he believes that's what actually won the election for Trump, partly, I should say. But yeah, I find it fascinating that more mothers are taking this holistic approach.
Mm-hmm.
And listen, your wife is a nurse. A lot of them aren't.
Yeah.
But what they're doing is they have the time to read. They have the time to
but
listen.
think about this. My wife's a nurse, so she's educated on this. So this is nurse to doctor.
Yeah.
This is like peer to peer. They couldn't get along on this. Like she looked at it as like I said, a God complex. Like we can't even have this. I'm in the medical industry. She is my wife. She is. My wife is very studied up on it, and I can tell you, there's nurse practitioners that are better than doctors. And my wife's about to be a nurse practitioner, and she challenged the doctor, the doctor of higher authority, of higher education. And it wasn't a conversation like, okay, Gina, my wife's name, well, I'll agree with you. Let's go this course, but I really think this is what we need to do. And this is the course I'd like to get you on. It's, no, get out of here. You're fired. Medical records. We don't treat patients like you.
Yeah. It's crazy. Like I said, I'm going to walk out of here today just hoping that we can create a change, hoping that this conversation allows others to get an insight into what is going on, because it's sad, it's scary.
It is.
And to hear someone of your statue talk about the fact that when you walk into a hospital, you're nervous and you're terrified, to hear you use those words, that should open up everyone's eyes that's watching or listening to this, because you live and breathe this for the past 20 years of your life. And if you're nervous, everyone else should be nervous.
I think at the beginning of this, I shared a statistic with you, and I think it was out of first-time diagnosis, statistically, and I'm not sure who provided me these statistics. I can get those for you for reference, but so first-time diagnosis being correct by a physician, 12%. First-time diagnosis being incorrect by a physician, 21%. If that doesn't terrify you walking into a hospital, an emergency room, especially at a critical time, the ability of the physician to figure out quickly what's going on in an emergency situation is critical at that point. And to have such a high, and this happened to me. I had something weird called a fixed drug eruption. I don't know if you've ever heard of it.
No.
So I play a lot of tennis, and I was having some swelling and some issues with my ankle. So at the time, a friend of mine was like, take some Aleve. It really works for me. I'd never taken Aleve before. Actually, I think I did. I took it much younger, but I usually an ibuprofen or Tylenol person. But they assured me this would work much better. So I took the Aleve. And I ended up getting a fixed drug eruption. I didn't know it was a fixed drug eruption at the time.
What does that mean?
Basically, my skin in certain areas of my body started to eat itself like a bacteria. So open wounds would just start bleeding.
Oh my God.
And I had it in some of the worst areas of your body. It was the most painful thing I had ever gone through in my life. It invaded parts of my urethra. I couldn't urinate. I was urinating blood.
Oh my God.
I was bleeding from the inside of my mouth. And I didn't know what happened. I actually thought it was some sort of infectious disease or what have you. And it cleared up the first time. So 5 months later, same thing happened. Hurt my ankle again and took a leave. Happened again. So I correlation. Something happened.
Yeah.
This time, because it was so painful the first time and I didn't seek treatment, I went through the whole process of fixed drug eruption. I went into the ER because I knew the worst pain was coming of my life, and I knew something was wrong.
Yeah.
Maybe I need a steroid, this otherwise. So I sat in a certain hospital here on Biscayne Boulevard for about 5 hours, and I saw 8 different doctors. Told every single one of those doctors that walked into that room that I ate a leave before this, and I had it happen to me before, and last time it happened, I had a leave. Leave couldn't cause this. No, it's not that. It's not this. We're not sure. We can't diagnose this. They tell me. I think they put me on a steroid that helped calm it, but I still went home with pain 8 hours later from that ER visit. And their recommendation was, look, you need to go see a dermatologist and an infectious disease specialist. Okay? So they couldn't diagnose it. So I see a great physician, dermatologist. His name's Dr. Martin Zayak. He's at Mount Sinai Hospital for the Miami Skin Center. And he's one of the best guys I know, and I have a good relationship with him. So I decided I would start there. So I went down and I walked in, and Martin's there, Dr. Martin. And I came in and he's like, so what happened? So I tell him the whole story. And he goes, same thing. Can you correlate anything with this? I said, yes. Every time it happened, I took a leave before it happened. He goes, I'll be right back. Comes back in 10 minutes later, and he has this huge book. It's about this thick, and it's a dermatology book. Like I guess they get in medical school.
Yeah.
He starts cruising through it, and he opens to this page, and he turns it around, and he goes, here, read this. And I start reading it, and it's exactly what happened to me. So it's a allergic reaction to NSAIDs, which are in ibuprofen, which are in, it's for anti-swelling.
Okay.
But it's heavy in Aleve.
Yeah.
Like whatever, because ibuprofen doesn't cause it for me. Aleve causes it.
It's
just a much higher
more,
dose or something's going on. But he came around and he nailed it. Came out and I just was like, wow. I looked at him. I'll never forget it. I look up and I go, do you realize I saw 8 or 9 doctors in the ER and not one of them could figure this out? And I go, and I told them all that I ate a leave before this. And they all 8 of them, 9 of them told me there's no way that could do this to you. I get out of the hospital. Well, I got out of the hospital before. This was after. So I leave Martin's office.
Yeah.
And now I'm enlightened about this condition. I have no idea about it, never heard of it before, never seen it in any of the patients that have come through our navigation company. And I just started talking to my friends about it. I said, hey, you ever heard of this? And believe it or not, I guess like maybe 1 in 1,000 people it happens to, or there's a statistic to it, but 2 of my friends it happened to. One of them, and it attacks anywhere, like wherever I guess the weakest point is. But I'm talking to my friend Giancarlo, and it happened to him. But it happened to him in his stomach, and it almost killed him. His inside stomach lining started to bleed and started to bleed into him to cause sepsis. He was rushed to the ER. They had to cut his chest open, going into emergency surgery to close it.
My God.
I had another friend of mine. He had fixed drug eruption too from taking a leave that I had spoken to. So as I started talking to people, I'm like, how do doctors not know about this? I just talked to 2 of my friends.
Yeah, they knew about it.
in the last 2 weeks after all this happened, and it happened to them. So this is clearly happening. People are aware of fixed drug eruption. How did 8 or 9 ER doctors, not one of them could go, well, maybe it's this. Maybe it's fixed drug eruption.
Crazy.
Never heard of it.
Crazy.
Same thing. So you want to know why I'm terrified? That's why.
Well, listen, Chris, you are truly fascinating.
Appreciate it.
And I hope to continue on our conversation later, because everything that you're bringing to light here is something that we should do this probably once a year, talk about updates, changes, more evidence, more statistics, more reason for people to listen to something like this.
Sure.
And I thank you as a human being for the work you're doing, because this is the work that changes the world. Changes the country for sure, but changes the world, because we need to hold people accountable. And I told you, at the end of the day, if the regulators aren't going to regulate the industry, the people will.
Yep.
And that's it.
That's what's happening.
That happens all the time in history, and people don't realize that. At the end of the day, the people get fed up with the BS, and they want to make the change themselves. So I think that change is clearly incoming for sure. The final question I ask almost every guest that comes on the show is, Chris, what do you wish you knew when you were in your early 20s? Doesn't have to be about healthcare. It could be about anything. But what do you wish you knew when you were in your early 20s?
I would say I wanted probably more fundamentals on what do I wish I knew. I think that I wish I knew the things I knew today, right? Earlier in life, right? Probably could have had more impact in what I do.
Do you think you could have learned it, or did that come with the experience of life?
I think it came with the experience of life. It's like being naive, coming into the business and letting the business shape you, and not you shaping the business you want it to be. And I think probably early on that happened. You end up in institutional companies that really shape your thought process. Tell you this is the right way to do things. And then you find out years later, I mean, this is the way you did things. I don't know whether they were the right things.
Right.
Right. And I think that but hindsight's 20/20, right? You can see all of that. But I think, having the knowledge to effectuate change, it would have been really nice to have it earlier and start my career earlier in doing that. It probably would have had more of an impact. I think would love to come back to, would tell you, and I think I'm working on some exciting things right now. I just have 2 months of data on a new program I implemented in a company that's saving them about $10,000 a month.
Amazing.
So I think next time we speak, I'm going to have more of that test case data to share.
I love that.
And it's really something new that we've employed that's really making a big impact. So I think I'll have more to share with you as we learn through this. And listen, I'm still learning things every day.
I know.
Some of the things like I showed you, the custom coding and this upcoding stuff. And it's, you zig, the industry zags. Right. And that's what I'm seeing. So, insurance companies and providers, they're, as these laws come through and we're zigging, they're zagging. And so new things pop up, and it's really interesting. I think it's a really interesting time in healthcare. I think the next decade, you're going to see an oceanic boundlessness in the shift of the way healthcare is administered. It's certainly coming down the pipe as more transparency goes and more people say, wow, is this really what's been happening?
Right.
And I need to take control of this situation. And I've been told for years I can't do anything about it.
Right.
But again, you can.
Right. 100%. Can you give some of your contact information so people can contact you if they want?
Yeah. You can reach me directly. I practice through Fortune Insurance, which is down in Coral Gables. We also, that can be Chris at Fortune Insurance, FORTUN insurance.com. You can also contact Navsys. That's our navigation company. That kind of sits as an adjacent product that plugs in and does healthcare navigation. So that's Chris at Navsys, NAVCES.com. It stands for navigation and access to the healthcare system, which having access to the system is a whole nother conversation, by the way. We didn't even talk on today.
That's why you got to come back.
Actually getting into the doctor you want to get into,
right.
And having access to that, which is a whole nother really insightful subject matter on this. But that's where I can be contacted. Phone number 786-344-9343. You can call me, text me. Listen, I work with other consultants too. I think I went back to tell you about loyalty. If you're loyal, I work a lot of times on side of a broker as a consultant to them. Not a lot of you call them brokers. I call myself an advisor.
Right.
They may not be up on this knowledge, and the employer wants to continue to work with them. I'll work adjacent with them and teach them how to effectuate these changes and realign their business and their partnership. If you have a partner broker you've worked with forever, maybe a family friend, maybe it's part of the family, and you
Right.
definitely don't want to, you want to keep them involved in that process. Navsess works alongside that broker to consult them, show them the point solutions. And so not only am I trying to change what the employer is doing, but I'll reshape the way that broker is, and I'll make that broker an advisor and a better advisor. So the
Love
more
it.
people doing what I'm doing as an advisor and getting out of the whack-a-mole and the broker and the spreadsheet, the better long-term everybody's going to be.
Right.
Because that's the value of it. So,
No, Chris, you truly, like I said, I told you, everyone that's close to me knows I'm not easily impressed, and I am fascinated by you because
Appreciate it.
I think that in the next 20 years, 30 years, we're going to look back and we're going to say, remember that guy, Chris, that came on our podcast? He helped shape this industry for the best.
So we're trying to.
So, Chris, you truly are the best of the best.
Appreciate
Thank you
it.
for coming on.
Thank you so much.
Appreciate you, and we'll definitely have you back on soon.
Awesome.
Thank you, everybody.